Hi, everyone, and thanks for joining us. I'm Dara, I'm the founder of Ayla, and for those of you who aren't familiar with Ayla, we're a healthy beauty company that's based in San Francisco, and we sell a variety of products from around the world with an eye towards efficacy as well as safety. And I was really excited to have this discussion tonight because perimenopause and menopause are things that many of us are either going through or will go through, but it's not talked about very much, which is interesting. And we hear about them a lot at Ayla, but indirectly, because a lot of people tend to go through a lot of changes in their skin and their hair as a result of it. And so for a long time, I was hoping to have a discussion on a more holistic level about why that is, because I think that the more you learn about something like this and the mechanisms behind it, the less scary it becomes and the more empowered you feel. So I was very excited to meet Dr. Tamara Neuhaus, who's here with us tonight. She's a chief medical officer at the Cusp, and I'm always happy to point people towards great resources. She's a fantastic one and uniquely qualified to speak about this topic. So Tammy, can you tell us a little bit about your background, how you came to be a menopause specialist, and what the Cusp is?
Yes, thank you so much for having me, Dara, and I'm really happy to speak to you and to your audience about this time in a woman's life. So yeah, my name is Tamara Neuhaus, and I am an OBGYN. And I always have said this throughout my life and career as a gynecologist and an obstetrician, is that I'm not just the president of the Hair Club for Men, but I'm also a member because I'm a woman. And so everything that women go through, I've gone through. I've gone through pregnancy and deliveries. And now I've actually gone through menopause already. So my situation is a little bit more unique, which I'll talk about in a minute because there were some questions from your audience about my situation and in general. But what is the Cusp? So the Cusp is a new medical digital startup in San Francisco, and we are basically partnering with our members in perimenopause and menopause. So trying to educate, be a resource for, and provide expert care for the management of perimenopause and menopause. It's a time in a woman's life where it's confusing, it's hard to identify, and oftentimes gets missed. It's an area that has been historically neglected by gynecologists and internists and family medicine doctors. And oftentimes women don't know who to turn to because their OBGYN is too busy delivering babies, and their internist or family practice doctor doesn't know much about it. And we need to find our own doctors to help us navigate this time in our lives. Not only is it hallmarked by symptoms like hot flashes and night sweats, irregular periods, mood swings, irritability, hair loss, acne, dryness, all these symptoms, but also we know it's a moment in our life's journey where we could make some positive interventions to both feel better and live longer, healthier, happier lives. So here at the Cusp, we're really trying to create a new specialty surrounding this midlife phase of women, for women, to get the care that they need to both feel better and live longer and happier, healthier lives. So that's a little bit about what the Cusp is doing. We basically put together a team of medical experts from different fields, including neuropsychiatry, gynecology, integrative medicine, naturopathic medicine, and dermatology, looking at best practices and what are the safest and most efficient, as you mentioned, ways to treat the different symptoms of perimenopause and menopause. And we're a full scope, comprehensive look at how a woman might want to seek treatment. We talk a lot about the very simple diet and lifestyle interventions that you can make to improve the quality, the quantity of your life. We also have a deep toolkit of botanicals and supplements that can help make you feel better, as well as both non-hormonal prescriptions. And then we do a lot of hormone therapy as well. I have been in practice for almost 18 years, which makes me feel very old. And my practice has evolved with me as I've aged. I started off delivering babies and practicing a full scope of obstetrics and gynecology. And then I've narrowed my focus. I had 3 babies in less than 3 years. And I took a little break.
I didn't realize that.
Yeah, I was highly efficient in reproduction, got an A+. And then I took some time off to sort of recover and went back to work practicing gynecology. And the practice I was in was a concierge medicine practice that really catered to essentially clientele over 40. And it was a moment for me to really start researching the key elements, both medicine and symptoms of perimenopause and menopause. Around that time, I also found that I am a carrier of the BRCA2 mutation that put me at significant increased risks for breast and ovarian cancer. So I went through a series of preventative surgeries and essentially chose surgical menopause to avoid breast and ovarian cancer. And when something is personal, you become very good at it. And so through that motivation to research and study and learn, I became certified by the North American Menopause Society and did a lot of independent research. And then through a mutual friend, I was connected to the CEO of the Cusp, and the rest is history.
That's great. Yeah, and I was really excited to meet you because there really aren't I haven't come across that many people who specialize in this particular period of life. And we can talk about that too as you go through this Q&A, but I found that really fascinating, and I'm just glad that you're here.
Yeah. It's an area that had, 50 years ago, a lot of women were put on hormone therapy when they went through menopause and perimenopause. When they invented essentially estrogen, they realized that you gave it to women going through perimenopause and menopause and they felt better. But if they only took estrogen, they got uterine cancer. So then they figured out, oh, there's two hormones you have to take if you have a uterus, both estrogen and progesterone. And then people were doing great, but they wanted to really study to see if it was making or improving their quality of life. So they released a huge study in 2002, about 100,000 women who were on hormone therapy. And this study had a huge media presence. And the study came out with mixed results, but what were highlighted were that hormone therapy increased the risk of certain cancers like breast cancer and caused cardiovascular disease or stroke or blood clots. And based on that, they actually halted the study and they took people off hormones. Mm-hmm. And because of the attention that study got, the past 20 years, people stopped studying hormone therapy or essentially even using it. And the field has been neglected. Mm-hmm. So rewinding to that study and what's changed now is even when the study came out, we knew it wasn't a great study. Those of us that were OBGYNs I was in residency at the time and learning about it, there were a lot of features that were wrong about it. The average age of the woman was 63, not around the time of menopause. They had a lot more underlying health conditions. And even the types of hormones they used in that study are very different from the ones that we use now. And then the good things that were in that study, like the decreased risk of osteoporosis, the decrease in diabetes, and certain other key features were swept under the rug. So we're spending the next 20 years, so now we've spent the past 20 years trying to unpack that and restudy hormones with newer hormones, bioidentical hormones, that actually do show to have less risks and far more benefits associated.
That's exciting.
I think I'm getting ahead of myself, and probably we should rewind and talk a little bit about some definitions. I know a lot of people are kind of confused. Well, what is perimenopause? What is menopause? What's the difference? Where am I? How do I know? And
I have to give a disclaimer.
Yeah. Oh, go ahead. Yeah.
I'm giving a disclaimer. What you hear here today is informational only and not actual medical advice. So Tammy can provide personalized medical advice to Cusp members during treatment, but for the purposes of this webinar, it's just broadly informational.
Yes, thank you for saying that, because people do tend to want to ask questions, and I'm happy to answer your questions in the confidentiality of a secure teleconsult.
Yeah, please, actually, speaking of questions, for everyone who's listening, please do submit questions to the Q&A feature. All of you are muted today. And you can also, if you want to keep everything private, you can submit a question anonymously. And the only people who will see the questions are me and the moderators. And then I'll ask them of Tammy, and I won't mention, so-and-so would really like to know this. I'll just keep it all nameless.
Excellent. So what is perimenopause? What is menopause? So menopause is the cessation of your periods. And way back before we had fancy ultrasounds and fancy blood tests, we had months. We had the lunar cycle. And we knew that if 12 months passed without a woman getting her period, that was menopause.
Okay.
And what we know is that women are born with all the eggs they're ever going to have as newborns, infants, where we start with all of our eggs. And once we go through puberty, every month, a certain number of those eggs will die. And sometimes, usually monthly you ovulate. And if you get pregnant, you have a baby. And if you don't, you have a period. And eventually the number and the quality of those eggs get so low that it causes your body's hormones and cycles to get irregular. So women's periods may start coming more close together, or they may start spacing out, and they actually may start skipping. And it's basically a function of not having that many eggs left over. And then eventually they run out completely and your periods end. So menopause is what we call a hindsight diagnosis. We know you're in menopause when 12 months have passed since your last menstrual period. For those of you that have had a hysterectomy like me, you go through surgical menopause. Obviously, you don't have a period to know if you are 12 months past your period, but you are essentially in surgical menopause, being that your periods are gone. If you have your ovaries removed, you're immediately in surgical menopause, whereas we've removed the source of your estrogen and some of your testosterone as well. For those women that have a hysterectomy, removal of the uterus and tubes and cervix, but they leave their ovaries, it's not always so clear. We know that those women can still go on and ovulate and have what I call a phantom period. So they might go through an ovulatory cycle, but there's just no lining in your uterus because you don't have a uterus that needs to come out. Having a hysterectomy can compromise the blood flow to the ovaries so that the ovarian function decreases and stops sooner. Or you may go on and go through a natural menopause. Like if you have a hysterectomy but keep your ovaries at 45, you may not get symptoms until you're 50, which is closer to the average age of menopause. So it's a little bit trickier to know.
Yeah. So actually we got our first question is related to this, which is how do you know you are in perimenopause then?
So perimenopause, we usually divide into two stages, the early stage and the late stage. And perimenopause can last anywhere from like 4 years to a decade. And it typically starts in your early 40s. And oftentimes women will start noticing that their periods vary a little bit more. So they used to be every 28 days. Now they're 25 to 30. It's a subtle variation, but it is a marker. There also might be more intense mood swings or PMS symptoms, more intense breast tenderness. There might be night sweats or headaches leading up to the periods. Women oftentimes notice changes in their skin like acne or feeling drier or having bouts of hair loss. And all of these are due to these crazy hormonal fluctuations that happen in this perimenopause. Like I said, the quality and the quantity of eggs start to decrease. So your body and your brain work harder to try and elevate the hormones that we need to kick out that egg. And so you have these erratic fluctuations of estrogen and progesterone. And when things are out of balance with estrogen, progesterone, and testosterone, you can get a lot of these symptoms.
Okay.
The later stage of perimenopause is usually when women start skipping periods. So maybe they only get 4 a year, or maybe they'll have one and then 90 days later and then 5 months later. That's a very common menstrual pattern as well. And it's just that you're not ovulating as frequently anymore, if at all, really. And then once you're in menopause, those hormone levels, which were fluctuating so much, they kind of find this low, steady state.
Okay. So someone else asked another very relevant question, which is, can perimenopause ever start in your 30s? My period started changing beginning in my 30s.
So
and
yeah.
Another question that I had, because as I was talking to people about how we were having this discussion, I talked to some people who said, oh yeah, my mom went through menopause really young. Does that mean that I'm going to go through it younger? And so I'm curious about the age ranges.
I mean, we are getting better at predicting when that menopause may happen. There are some hormone tests that we are analyzing, looking. One we've stolen from the reproductive endocrinologists. They look at how many and how good the eggs are in trying to predict an IVF cycle. And now we look at that same number to try and predict when they're going to run out. So we're just looking on the other side of it. But there is premature ovarian failure and early menopause, which typically is defined as before 40. And there are certain autoimmune conditions that can predispose to that. There's some genetic conditions that can also predispose to that as well. We do tend to mimic our mothers in a sense, but you also can have your own individual journey as well. Menstrual changes in your 30s and even in your early 40s. And if you find yourself talking to me or one of my other providers at the Cusp, there are other things that can mimic perimenopause. Thyroid disorders, very rarely there can be a tumor in the brain called a prolactinoma. There are other things that can sort of mess with your period that are important to exclude when you're thinking you might be perimenopausal.
Mm-hmm. Okay. Another question. Someone wrote in, she said, I had a full hysterectomy in December. Am I in post-menopause? She said, am I in post-menopause or menopause? Since I have an actual date of when periods stopped. And if it's post-menopause, are the ways for managing symptoms different?
So that gets back to what I said earlier. Obviously, I don't know if she has her ovaries or not.
Mm-hmm.
She will never have another period again. So if you're using the, historic definition of menopause, she's in menopause because she doesn't have periods anymore, but she might still have functioning ovaries that are protecting her from having symptoms. The management of perimenopause or menopause, the symptom management, if you don't have a uterus, then you don't have to take progesterone, which is that hormone I briefly mentioned that protects against uterine cancer. So she's an excellent candidate for estrogen therapy alone, which is a very, very safe group to be in, because that study I mentioned earlier, when they looked at the women who had a hysterectomy and took estrogen alone, this group actually had a decreased risk of breast cancer comparatively.
Oh, interesting. Wow. Okay, I'm not an excellent multitasker, so I'm
I'm not either. I'm happy you're doing that, not me.
going through the pre-sent questions and the ones that are coming in real time. So one that I know we had talked about before and you thought was really interesting was about perimenopause and irregular menstruation. Is infrequent or irregular menstruation every 4+ months harmful? For example, does this create lining buildup that fosters polyp growth?
So I love this question. This is somebody who's done some reading and she sort of knows what she's talking about. In a menstruating woman, having a period every 4 months would not be normal. Usually that's an ovulatory dysfunction or something is not quite right there. And if you don't shed that lining of the uterus every month, you can be at risk for precancerous or cancerous changes of the uterus or benign conditions like polyps. Although polyps don't usually arise from having a buildup of the lining, but they can be the cause of a buildup in a lining. And so if women aren't properly shedding their uterus, we do usually evaluate that. If you're in the classic age range for perimenopause and your periods have followed a pattern of being monthly, then skipping, then spacing out, and coming every 4 months, we don't really worry about the lining of the uterus. Remember that the lining of the uterus builds and sheds every month based on this dance, this choreography between estrogen and progesterone that prepares the lining of the uterus for implantation following ovulation. And then when the hormones, if you don't conceive, then there's this very coordinated sloughing or shedding of that lining of the uterus. And so if you don't ovulate, you're actually not preparing. If in this perimenopause, you're not growing an egg, you're not even growing a lining. So after menopause, the lining of the uterus becomes very thin.
Okay.
Was that a good enough, does that make sense to you? Okay.
Yes, for sure. I'm also slightly,
Are you asking for free medical advice, Dara? No.
no. I was gonna say, I'm like a little bit, I'm trying to multitask and I'm trying to lump the questions together so that they're sort of by topic. So a couple more about perimenopause and menopause. There are some questions about whether or not these stages look different if you haven't had children versus if you have, or if you've had conditions like endometriosis.
So that's a great question too. So there was a great article that came out recently, an anthropologic article looking at is the fact that women are having babies later pushing menopause later.
Yeah.
And we are looking at the evolution of menopause. And it's hard to know exactly what's the chicken and what's the egg, no pun intended. Are women able to reproduce later in life because they have a larger amount of eggs? So they're more fertile later in their life. And does that mean their natural menopause would have happened later? Or is there something about having babies later in life that pushes off menopause? I don't know the answer to that, but there really isn't a correlation. Even if you are pregnant, eggs still die. So it's not like having children staves off your menopause.
Okay. And then with conditions like endometriosis, that was another related question.
Endometriosis is a complicated disease. For those of you who don't know, it's when the lining of the uterus grows outside of the uterus, whether that's on the surface of the uterus or on the bowels or the ovaries or in the fallopian tubes. And it can cause very, very, very painful pelvic pain, pain with sex, pain with ovulation, and it can cause a lot of scarring and buildup because that lining, that endometrium, which is outside of the uterus, that's where you get endometriosis, it grows and sheds. It responds to like the hormonal tides that the lining inside the uterus does. And all of that activity can cause scarring and damage. So women with endometriosis who are very extensive, they can have a lot of scar tissue surrounding their ovaries that may compromise their function. A lot of the treatments for endometriosis are suppressing ovulation or inducing menopause because we need to remove that tissue or stop that tissue from coming alive and shedding every month. The most significant treatments for endometriosis is medically induced menopause with something called Lupron, or even a hysterectomy. And these women, if they do end up with a hysterectomy or removal of their ovaries and their uterus and tubes and everything that's affected, they actually do very well with estrogen replacement afterwards.
Okay. So I thought that might be a good segue. There are a couple more questions about perimenopause, but we're also getting a lot of questions about hormone therapy. And so I thought we should dig into that. And if you could just start off with a broad, because I know nothing about this, I'm curious too. How do you evaluate if someone's a good candidate for it? What are the options? How are the hormones taken? Are they taken every day? How does this all work?
Yeah, that's a great question. So as I was alluding to when I was talking about that study earlier, a lot of women stopped hormone therapy. But what we do now is we use bioidentical hormones. What does that mean? That means that the hormones, the estrogen and the progesterone that we're giving the woman are identical to the type that we make in our body. What they used in that study where they were synthetic, one of them was derived from the urine of pregnant horses, and the other one was a synthetic progestin. And like I said before, the women in that study that took both estrogen and progestin, they were the ones that had the higher risk of breast cancer. The women who took estrogen only had a lower risk. So we've been pretty sure that what can increase your risk of breast cancer with hormone therapy is progestin. So we've been making that better. So the bioidentical progesterone has a lower risk of breast cancer based on early studies, and we're constantly evaluating that right now. So who is a good candidate? So what is hormone therapy? So basically we've just said that your hormone levels, your estrogen, progesterone fluctuate erratically during perimenopause, and then after menopause, they fall and they're very low. And we have estrogen receptors everywhere in our body, and it plays a vital role in keeping our brains alive, our skin alive, our digestion active, our heart healthy, our fat in a female distribution. It's a very important hormone. And when we withdraw from it, we get hot flashes and night sweats and irritability and mood swings, vaginal dryness. I mean, the list goes on and on. And so the goal of hormone therapy is really to relieve those terrible symptoms. Some women, we can treat those symptoms with non-hormonal or lifestyle or botanical supplements, but some women really do best with hormone therapy. So
based on the severity of the symptoms, or just who they are, or both?
Correct. The usually the most frustrating symptom of perimenopause and menopause are hot flashes and night sweats, which is when your body abruptly gets hot and cools. And we think it's a phenomenon of the thermoregulatory zone in the brain, which narrows, and small triggers can send you off needing to cool. Triggers can be temperature changes, exercise, spicy foods, caffeine, what else? Hot beverages. All of these things are exceptional triggers for hot flashes and night sweats. And we are getting better at treating them non-hormonally, but estrogen is the best and the fastest way to make them feel better.
Okay.
But what are the key features of being a candidate for hormone therapy? Well, it's a conversation. There are some absolute blockers, like a history of uterine cancer or breast cancer, a history of a blood clot, like a DVT or a pulmonary embolus, or having a genetic mutation that predisposes you to one of those things, which can run in families. Certain liver or gallbladder disease or undiagnosed bleeding are all reasons we wouldn't recommend it, or having a significant family history of breast cancer. We also don't give it to women who are already at a significant risk for cardiovascular disease. Interestingly, we do know that starting estrogen therapy close to menopause within 10 years actually decreases your risk of cardiovascular disease and decreases your risk of certain other cancers like colon cancer and decreases your risk of diabetes. We've known these things for a very long time, but it's just weighing the risks and benefits based on your own personal history.
Okay. And what are the most common non-hormone treatments?
So we divide non-hormonal treatments into prescription and non-prescription. There's a number of herbs out there that have been around for thousands of years. There's Chinese herbs, and then there's, roots like black cohosh and maca and Siberian rhubarb. And there's some studies that suggest that they may help certain women. Certainly not everybody, but some people do really well with something like that. Mm-hmm. And again, we're mostly talking about hot flashes and night sweats here. There's other supplements for mood swings and irritability and sleep support and whatnot. And then for non-hormonal prescriptions, there's a number of medications that actually can work quite well for blocking hot flashes and night sweats. There's some chronic nerve pain medications that we use, something called gabapentin, can be as effective as estrogen for night sweats, which are when they happen at night, when women wake drenched in their bed. And then some of the SSRIs and SNRIs, which are low-dose antidepressants, can work very well for both the hot flashes and night sweats. Again, we think it happens in the brain, and these are, serotonin and norepinephrine receptor inhibitors that help modulate brain chemistry. So they can be very effective, and then you get a little boost of your mood support there too.
Okay. So there's a lot of options.
There's a lot of options, and finding somebody who is well-versed in all the options is like the number one thing anybody can do.
I can imagine. So we also I love this question, it's really fun. If estrogen is so important, why have humans evolved to lose it? So is the estrogen therapy to reduce the symptoms, or also to keep your brain alive or for digestion, etc.?
So this is a great question. And in fact, when you go, again, looking at the anthropologic studies around menopause, clearly you're right. It's evolutionary. We are not meant to have babies after a certain point in our life. So our eggs go away and we stop producing estrogen. But what does that mean? Because human beings, women, clearly live for a long time after the age of 40. And there's a wonderful hypothesis called the grandmother hypothesis that women were helpful when they weren't reproducing. They could gather food for two people. They weren't breastfeeding. They could help take care of the kids. So evolutionary, it behoved, is that a word? I don't know. It was good for evolution to keep around these women, even though they didn't have estrogen in them. And then you can argue, so why do we give it back? Well, like I said, like it does famously treat the symptoms that you have. And we do have really good studies to show that it is a highly protective hormone. It is highly protective of the bones in preventing diabetes, in, getting buzzed. It is highly protective for all of these features. And we know that estrogen is this amazing hormone with all these receptors. There's really great studies coming out right now out of the Weill Cornell Brain Center that it probably helps prevent Alzheimer's dementia in women. And wow. It really comes down to choosing your risks and benefits. Historically, we've used it and recommended it to treat symptoms and not prevent disease, but it's a fine line and it's a personal choice on whether or not you want to take hormone therapy or not.
And how long do people stay on it typically?
So this is a constantly evolving question. Back in the day, everybody took it. I remember my 97-year-old grandma, when she died, she was still on estrogen therapy, right? Wow. And so, I mean, she had a hysterectomy, so she's a little bit different, but still. And then when they had that release, that study, everybody came off. And the recommendations were to use the lowest effective dose for the least amount of time. But we're loosening those restrictions all the time. In fact, the North American Menopause Society, they released guidelines in 2017 that said, it's a conversation. If a woman wants to continue her hormone therapy past the age of 60 or past the age of 65, you just have to discuss the risks and benefits. So there's not a one size fit all when it comes to that answer. The nice thing is that there's more and more people doing research on the beneficial components of hormone therapy, as well as the detrimental, and who's at risk and who isn't. And as we get more and more information and data, we will constantly, stay abreast of that information.
Okay. Yeah, we also got a related question. If someone can safely take hormones if they started taking them in perimenopause, how early would you say? I mean, I'm sure it varies quite a bit, but typically at what point do people start hormone therapy in this journey?
When they're symptomatic, and that may be in their mid 40s and it may be in their early 50s. When we look at the risks of hormone therapy, we only start it if it's been within 10 years of menopause. We don't like to start like a 62-year-old who went through menopause at 50 on hormone therapy. That does increase her risk of cardiovascular disease. But with the closer you are to the timing of your menopause, the better once you've gone through menopause. I mean, a lot of women in their 40s are still on birth control because guess what? You can still get pregnant. It's a very low, rate, but it is a possibility. So we don't generally start the clock ticking when you start it under 50. There's other risks with taking hormones your whole life, but that's another conversation.
Yeah. We also got a whole bunch of questions about hair. Where do I start? Let's start with this one. Because she gave a lot of good detail. I'm 47 years old and going through menopause. I'm working with a naturopath and an herbalist who came up with a supplement regimen that's worked wonders for me. But my biggest concern is my hair. I've been taking biotin daily for almost 6 months now with no changes. I eat a plant-based diet. I'm very healthy. I practice yoga. My hair loss is unreal. It's thin, lost all volume, help. I've gotten this question a lot.
Yes,
what do you think?
Yes. I've
You
got this question a lot too. I mean, estrogen is an amazing growth agent. And oftentimes when your estrogen levels are fluctuating, you can have hair loss. Or when they're low and your testosterone levels are higher than your estrogen, you can also have hair loss, in the male pattern baldness sort of distribution, or just in general. I mean, there are other health conditions that can cause hair loss, like iron deficiency anemia, certain thyroid disorders. So there is and zinc disorder. So there's certain workups that we do for hair loss, and you can take supplements and you can do other things, but a lot of time hormone therapy, women do notice that suddenly their eyebrows grow back or their eyelashes get longer, or their hair gets thicker again as well.
Mm-hmm. And do they also find that it alleviates facial hair growth, for example?
Oh yeah, facial hair growth is a good one.
Yeah.
Yes. I mean, facial hair growth is also complicated. It's usually an imbalance, not necessarily related to just one or the other, but it's when your hormones are out of whack that you can see more hair growth on your chin, on your nose, more acne, all of those things as well.
Okay. So generally, the answer to the hair loss is looking at hormones. We've got a lot of other questions about hormones that are really good. So this person asked, if you've had trouble in the past tolerating hormones, for example, birth control pills, can you still be a good candidate for hormone therapy in menopause?
So the answer to that is quite possibly. So birth control pills are estrogen and progesterone, but different formulations. And they're at significantly higher doses, because birth control pills have to be stronger than what your body does in that ovulation dance. So birth control pills block ovulation, and that's how they prevent pregnancy. The doses we use for hormone therapy, and we start small and work our way up, we're just adding it back to the level where you feel good. We're not preventing pregnancy with hormone therapy. And also, a lot of people don't do well with birth control pills because of the oral ingestion of them, which can cause nausea and upset stomach and bloating and a bunch of side effects. But hormone therapy, I think we kind of talked about this before, comes in lots of different formulations. We usually start with, at the Cusp, and I prefer, and I use an estrogen patch, which is a transdermal delivery, which bypasses the first pass through the GI tract and the liver. So there's a significantly less amount of side effects with that.
Oh, interesting. All right, I'm trying to decide. There's so many good questions. I don't know which one to go to first. This is jumping around a little bit, but I want to make sure we cover this because we've talked about this before, and I love this question. I love this topic. So this person wrote in, I'm wondering if you could speak to menopause as a process of transformation and coming into our power as women. I'm 53. I've been going through menopause for the past 2 years. It's been a powerful process and time in my life. I've experienced the hot flashes you described very regularly, about every 2 hours at night.
Oh no.
Yeah, she said, this may sound odd, but I generally don't mind. This is fertile time. I meditate, I follow my dreams. I try to touch into the liminal space of night, to borrow from David White. This is awesome. However, I want to get enough sleep. As a naturopath underlined to me recently, and I've developed dark circles under my eyes this last year. Would love to hear your insight about sleep. So I think it's 2 questions. It's, can we talk a little bit about this change in this period as a positive thing? Because we also got a question that was, is it all just downhill from here?
Yeah.
And then the question about sleep.
Yes. Okay. So I love the idea and the analysis of menopause as a transition. I mean, like, it's like a phoenix rising from the ashes, right? I mean, it's a wonderful time to celebrate that. First of all, you can't get pregnant anymore. You don't have periods anymore. A lot of the terrible symptoms of menopause do abate within the couple of years. The hot flashes and night sweats, they do go away. The mood swings, the irritability, you do tend to even out. There are some features of menopause that will haunt you, and hope we can talk about the vagina at some point. But it is definitely a time where women feel more empowered. They feel wiser. They've crossed over onto another side. And you've got like another hopefully 40 years to explore the things that are important to you. And your kids are much older now, or if you haven't had kids, you've gotten further in your career, or both, or whatever it is you've done. And it's a wonderful time to focus on those positive aspects. It's not the end of, like, I don't define myself by my fertility or by, youth and whatnot. Like you need to embrace your whole self, and there's wonderful opportunities that lay ahead of it. As far as the sleep goes, I mean, sleep is probably the most important thing your body needs, next to water. And if you don't sleep, your body doesn't repair itself, and the features that make you can break down. Dark circles is probably the least of the worries. Hot sweat, night sweats every 2 hours is terrible. That there's a lot of things that you could do to try and cut that back, both naturally with some lifestyle changes and dietary changes, exercise changes, maybe even botanicals, or even non-hormonal or hormones if you wanted to go that route, because the sleep deprivation can be really hard. I mean, it can cause weight gain and fatigue and brain fog, and probably some cancers and whatnot. So I think that there's a lot to do to improve the sleep.
Okay. I'm sure this is varies again from person to person, but like, what are some general go-to remedies for that?
For sleep. So when we talk about sleep disturbances, and there's been whole books written on sleep disturbances, like what's keeping you up at night? Is it because your bladder is having spasms, so you have to pee every 3 hours? Is it night sweats that are waking you up, and then you have to change your pajamas and put down a towel, and then you're wide awake and can't fall back to sleep because you've got stress at work? Anxiety and stress are huge things that wake us up in the middle of the night. Partners can snore, kids can disrupt you. So generally speaking, creating and setting up a proper sleep environment is ideal. And then breaking it down and looking at what are the things that are waking you up. Are you being woken up, or is it that you can't fall asleep? Or if you wake up at 3 a.m. every morning and you can't fall back asleep, and then you anticipate not being able to go back to sleep, and you get yourself in a symptom. So just on a very, very simple level, there are certain things that you can practice. We call it sleep hygiene. Making sure that you're not drinking too much liquids after 8 p.m. so that you're not up having to pee in the middle of the night. Making sure you're off your screen so that your brain has time to unwind. Keeping the bed for sleep and sex only. You shouldn't read a book in bed. You shouldn't scroll on your phone in bed. You shouldn't do work in bed. It should be a sanctuary for that. I talk a lot about having a very good space between when you finish eating and when you go to bed. Bed should be sleep should be restful. You should not be digesting food. It's also important not to exercise too close to bedtime. This can raise your core temperature, which is going to set you up for night sweats. Exercise should be done in the morning. So all of these small things can help, adjust your schedule to help you sleeping better.
Okay. I'm also gonna switch and talk about a couple of questions that are in the perimenopause bucket again. Okay. So question number 1. Are heart palpitations and forgetfulness also possible symptoms of perimenopause?
You betcha. Heart palpitations sometimes are a feature of a hot flash or a night sweat. Any heart palpitation should have a proper workup, like a thyroid evaluation, an EV evaluation, an EKG, to make sure there's nothing underlying happening. But that is sort of some women's feature of almost like a hot flash. Forgetfulness, brain fog, being slow to remember words, these are absolute symptoms of perimenopause and menopause. And is it because you're not sleeping at night, or is it actually because the hormones in your brain have changed and you're unable to process things as well?
Mm-hmm.
Untreated, oftentimes that does get better once a woman passes through menopause. Although, like I said, we are seeing some research that says estrogen is important in preventing Alzheimer's dementia. But, starting with sleep, it always comes back to sleep as the number one thing to sort of repair.
Okay. And then we also get another question. Are there simple dietary changes that can be made initially to help alleviate symptoms of perimenopause before stepping into all the other options?
Absolutely. And sometimes it's a function of avoiding the triggers for your hot flashes or your night sweats, like spicy foods, caffeine, alcohol. Red wine is a killer for night sweats. Avoiding hot beverages, temperature issues with food. We also know that eating a low glycemic index diet, so high protein, lots of fruit and vegetables, is better than high carb, sugary, white food, whether that's bread, pasta, or popcorn. Because you will have less spikes in your blood sugar, and having a nice even blood sugar, especially while you sleep, really helps to get into a deeper, more restful sleep. Sometimes it's also a function of not what you're eating, but when you're eating. And like I mentioned before, finishing your meal a good 3 to 4 hours before you go to bed is ideal in setting yourself up for a better sleep.
Okay, great. We also get a lot of questions about dryness, dry skin, dry hair, whether during perimenopause or menopause. So for example, I'm 45 and still have a normal menstrual cycle. I've always had oily hair and skin, but recently last year, my hair has been exceptionally dry. I have dandruff for the first time ever. Could this be a symptom?
And it might be, again, this would be somebody who would need a full, workup, make sure her thyroid is functioning, check for, vitamin disorders or anemia and whatnot. But yes, I mean, estrogen is a key feature in our body for both hydration and lubrication. And we do know that everything dries or slows when we withdraw from estrogen, whether, and I talked about this in the blog, whether it's your eyes. Dry eyes is a feature of perimenopause, or your hair, your skin. And then if you let me, I'll talk about the dryness of the vagina that happens as well. All of these tissues have estrogen receptors. And when we withdraw from estrogen, the skin changes. It's particularly the mucosa of the vulva, which is the outside of the female anatomy, and then the vagina, which is the inside. And one of the simplest and most important things a woman could do is recognize if they're noticing vaginal dryness, irritation, pain with sex. Most women will suddenly just think they need to use a lubricant because their libido has changed, but almost everybody is needing a lubricant because it's just naturally not there. So giving the vulva and the vagina estrogen back, which is actually exceptionally safe and can be done for anybody without any sort of contraindications, because it's a local delivery, doesn't get absorbed into the whole body, but it improves the elasticity, it improves collagen production, helps bring back lubrication and moisture. It's actually one of the easiest and simplest things you can do.
Wow, okay. Yeah, related, someone said, I'm using hormone therapy for hot flashes, but what could be helpful for continued dry skin challenges? Are there dietary changes, supplements, or the things that could be helpful?
Well, depending on, again, this is somebody who should probably, have her hormones looked at, make sure she's on the right doses. Hydration is something we all battle, especially when we're home in our houses and whatnot. But using appropriate sunscreen and a really good moisturizer at night can help as well. I mean, our skin barriers do break down as we age, and estrogen helps protect that. But you probably want to make sure that you're using the right amounts for everything.
Okay. Yeah, we get a bunch of questions about dryness, so just making sure we covered everything. This was an interesting one. She said, I'm perimenopausal. My skin's much drier than it's ever been. Drinking a lot of water. I think there's a question about, is it too much water? Are there other ways to promote skin hydration from within?
Water you don't have to drink too much water. And at some point you'll reach a point where, you actually can cause a sickness from drinking too much water. You probably, the standard 6 to 8 glasses a day is what people recommended. But really, there's no science behind that. You drink until your thirst is quenched, basically. But I think that using appropriate moisturizer is key. Avoiding the sun. Certain features are dehydrating, like the sun, caffeine, and alcohol. This is dehydrating for the whole body, which can suck moisture out of your skin.
Okay. And I love this question. It seems like a lot of the triggers and symptoms for menopause are similar to rosacea: caffeine, red wine, dry eyes, skin issues. Why is that?
I mean, rosacea is a complicated disease. It's sort of acne. It's also very inflammatory. And a lot of that is probably due to the estrogen. And as your estrogen wanes, you're not having the protection against that inflammation and against that that irritation. So I do think that, I mean, my husband's a dermatologist, and so we talk a lot about treatment of rosacea and is it is it antibacterial important? Is it laser therapy? Is hormone therapy? I think that's very multifactorial. I don't think there's an easy answer for that one.
Okay. This is an interesting one too. How does exercise affect your estrogen levels? Can over-exercising temporarily decrease estrogen?
So in general, an appropriate amount of exercise is like the single most effective thing you can do to feel good, live better, and prevent cardiovascular disease, diabetes, depression, a number of cancers. We know that. But in those individuals who over-exercise to the point where they lose body fat, or we see it with anorexia, there's a classic disease called the female athlete triad, where women basically exercise to the point where they're unable to make hormones. That is a very extreme case. Whether you exercise or not is not going to affect your estrogen. If you're a normal woman, is not going to affect your estrogen production through perimenopause and menopause. You cannot control that. But you can feel better and have fewer symptoms of perimenopause and menopause if you do live an active, healthy lifestyle.
Okay. I'm thinking we probably have time for a couple more questions, and I love all the questions that people have sent in. And if we don't get to your particular question, apologies in advance, but it might be a case where it's specific enough so that the Cusp team may want to write you a little note separately, or there are just too many of them and we can't get to them, which is a great problem to have. I love all the questions. We got a couple more questions about food, so I thought we could cover those. Do foods with natural hormones like eggs and milk affect perimenopause or menopause symptoms? And also, sort of related, is there any clinical data suggesting that a plant-based diet is better than a non-plant-based diet, or vice versa, specifically related to protein intake?
Probably a plant-based diet is better for everybody, including the animals and the earth. Whether or not it's going to allow for an easier perimenopause or menopause, I don't know the answer to that. I mean, they've looked at high soy and yam, which have phytoestrogens, plant-based estrogens. You have to eat a lot of those things to sort of replace, the estrogen that you're losing in your body. They weakly bind to the estrogen receptors that we have, but they may cause an effect. So that there is some thought with that. Milk and eggs, I'm actually not aware of any research that says that would help you to go through perimenopause or menopause. I mean, some people have intolerances to lactose or they're allergic to eggs or whatnot, but there's no research to suggest that eating those things would help or hinder the process.
Okay. And we might be able to get to these last two quickly. I've read that it's best to use natural estrogen hormone. Is that true?
So the two hormones that the bioidentical, which is 17-beta estradiol and progesterone, they are both essentially synthetic, but they are derived from plants.
Okay. And then this last question would be interesting to see what both of us would say. Are skincare products directed towards menopausal women just marketing tactics?
So yeah, what Dara and I agreed not to discuss this. So I'm married to a dermatologist, and if you are a dermatologist or married to one, you use retinoids, you use hyaluronic acid, and you use Latisse, and you use like hydrating products, and you use sunscreen. I don't tend to spend money on skincare products, but I also have unlimited access to
Yeah.
and anything else I want. So it's sort of a loaded question for me.
Very, very lucky. Okay, well, and we'll do this one last one, and then I'd love to hear if there's anything else that you want to talk about. Can you talk more about weight gain and perimenopause? What causes the weight gain, and does taking hormones reverse those changes?
Ooh, how did we not get to this question
I don't know,
sooner? Oh
actually.
my gosh, it has a belly, the menobelly. A lot of women in perimenopause and menopause note that they start putting weight around their belly, like a spare tire, and they never had a belly before. And we actually do see that a lower level of estrogen leads to this deposition of fat around the middle. Weight gain in general happens in the midlife phase. You can't necessarily blame it just on hormones, but we can blame the location of it on a lower dose of, or lower level of estrogen. So when we do put women on hormone therapy, they may lose weight. You have to try, you have to, lose weight, but it does help redistribute that fat. So you put it back in your hips and your belly and in a more classic female appearance.
Okay, interesting. Is there anything that we haven't covered that you think is just a hot topic that we should? Anything, any other pieces of information or advice that you want to pass along, just given what we've discussed so far?
I think we've covered a lot. We definitely went head to toe. We talked about brain and hair and skin and some breast and definitely vulva and vagina, which is great. I mean, I think that what I really want women to know is their own bodies and what works for them, and to know that there are lots of options. It's not a cookie cutter approach. You should weigh your own risks and benefits and do the things that you can do. And really the goal is to feel better and live a healthier life. And there are so many steps that you could do very simply starting now to affect those changes. And that's my biggest take home message that I like to share.
Great. Well, thank you so much. This has been fascinating, and I've been just really impressed by how you have just covered everything so fully and completely. And so I know that the Cusp is going to pop in with a disembodied voice to
Thank you. That's me.
to offer something very nice. Thank you guys so much for organizing this and for basically doing all of the work for us, and for Tammy's wonderful answers. This has been everything I'd hoped for and more, and I hope we can do more of these.
Thank you for having me, Dara.
Yeah, we hope so too. Thank you, Dara, and thank you, Tammy. And thank you for everyone. My goodness, 30 questions, 30 plus questions. Thank you guys for all of that today. A lot of them, there were some pretty specific questions out there, and I hope you guys didn't mind me directing you to the Cusp for those of you that did have specific questions. But for more details about the Cusp and information about our personalized telemedicine services for perimenopause and menopause, please go to meet.thecusp.com/Ayla. And we want to give all of you guys $51 off at checkout for any of our packages. We have a surgical menopause package, we have a symptom management package, and a hormone therapy package. It's 3 months of care with Dr. Tammy and her team. She has a lot of clinicians on her team that are pretty amazing. And she has, as she talked about earlier, a whole slew of resources at her disposal, from neuropsychiatry to breast surgeons to cancer specialists who really understand menopause and perimenopause, at her disposal to help you get the care you need. And I'd also like to put a plug in. If you'd like to host a future event with the Cusp, we do all the work. There's a lot of people in the background here that you guys aren't seeing or hearing. And just let us know if you have a subject you'd like for us to tackle in the future, whether it's with Dara and her community or just some subjects you'd like us to tackle in the future. I think we might enlist Dara's services full on in the future to do these things, because Dara, you're a fantastic interviewer and you did such an amazing job navigating all the questions. Thank you for that. Yeah, it was really great.
For everyone who's listening, by the way, I've never done one of these before. And when we were all getting on the Zoom before we let you all in, I was like, do I look at this green dot the entire time? That's making me crazy. So thank you guys for making this so easy.
Well, you were amazing, and you have another career in being a Zoom moderator, so thank you. So please email us at connect@thecusp.com. Let us know what you think. Let us know what other subjects you want us to tackle, and let us know how we can help you. I'm Valerie Williamson, and you'll be emailing me. So I look forward to talking to all of you, and thank you so much for being a part of this event and participating. And thank you to Dara and Tammy. We're very grateful for this hour that we all spent together. Thank you so much.
Thanks. It was such a pleasure.